Audible?
Perfectly, sir. Sir, can we start?
Sure.
Yes, sir.
Yes, please.
Good evening, ladies and gentlemen. A very, very happy new year 2024 to all of us. Welcome to Pearls of Critical Care, and today's topic is end of life clinical case discussion. We are also very happy to update you that today we complete exactly 1 year. Today is episode 12. And all this has been possible because of our course directors, Dr. Yatin Mehta and Dr. Dhruva Chaudhary. Tireless effort to bring the pearls of critical care, not just now to India, but so many other countries as well. A warm welcome to Dr. Yatin Mehta and Dr. Dhruva Chaudhary. On the same breath, I would also like to welcome our experts. A detailed introduction will follow. Dr. R.K. Mani and Dr. Sanjeev Kumar Arun Jha. Gentlemen, I'm not able to change the slide. Okay.
Click on the slide.
Paresh,
Click
can
on
you
the
just
slide
load the
and-
slide?
Yeah, just click on the slide.
Yes, sir.
Ah.
I'll share this.
Just go down to the introduction one, please. Sorry about this glitch. All of us know Dr. Yatin Mehta and Dr. Dhruva Chaudhary sir very, very well. But some of us who are doing DM, DNB courses, a little detail about them would help you understand which pathway to choose in your career. Today we will close at 9:30 or something like 8:30. It's my honor and privilege to introduce Dr. Yatin Mehta sir. To me, two words comes to my mind: an institution creator and teacher of teachers. Dr. Yatin Mehta is chairman Medanta Institute of Critical Care and Anesthesiology at prestigious Institute of Critical Care, Medanta, the Medicity, Gurugram. I can take a few hours to introduce him, but just to keep it very brief, he has been a trainer par excellence, an institution creator par excellence. He went on to create the Scott's Heart Institute Department of Critical Care, and from there moved on to Medanta, and a proud alumni of All India Institute of Medical Science. At national and at global platform, he has provided immense contribution to the field of critical care. Gentlemen, 33 chapters in books, 360 plus publications, 560 plus presentations in conference of international and national repute. Many awards and accolades to Dr. Yatin Mehta's credit. Medical Doctor of the Year, Vashisht Chikitsa Ratan Award in 2012, Dronacharya Award in 2019, and Guardian of Healthcare Award in 2021. So some of us who are bringing our career in critical care, this is one pathway to follow. Our second program director, full of energy and a great contribution to the field of critical care, Professor Dr. Dhruva Chaudhary, sir. We know him very well, but I'll keep it brief. Senior Professor and Head Department of Pulmonology and Critical Care at prestigious Postgraduate Institute of Medical Science. Again, another academician, presenter, and institution creator par excellence. Many awards and accolades to sir's credit, but I will tell you, the field of academics and field of critical care supervised 30 plus postgraduates in medicine and allied subject and 14 postgraduate fellows, written more than 42 papers in national and international journal and 38 chapters in books. He also edited a monograph on antibiotics uses and abuses, so apt in today's world. Past Vice Chancellor of Indian College of Critical Care, IACCM, and has served the field of critical care into various domains. Sir, both of you, it's an honor and privilege to get associated with you, and no wonder that this is already finished 1 year and we intend to continue it for long. May I request both of you to introduce our experts and presenter today. Thank you.
Thank you, Manoj. It's indeed a pleasure to be here, and I think it's a great day because we finished 1 year of points of critical care, and I think thanks to Dhruv mostly, because we have discussed these things that we want little off-label subjects to be discussed, because which are not commonly discussed in the conferences. I mean, we have a lot of sepsis and ARDS and hemodynamic management and so on and so forth, but these are the subjects which are not touched that much as what they deserve to be. So it's a pleasure to have Dr. Mani. He's a dear friend of mine. He's MD FRCP, FICM is Director of Clinical Services at Yashoda Hospital, Ghaziabad. He was past president of Indian Society of Critical Care Medicine, and he was chief editor of the Indian Journal of Critical Care Medicine for many years. And career spanning 40 years, he can take credit for establishing the specialty in many major hospitals of Delhi. And I must say that he is, if you talk about end of life care, I think the one name which comes to your mind is Dr. R.K. Mani. I think he has done so much of work on this field, not only academically, but also ethically and legally speaking, because he represented Indian Society of Critical Care Medicine when the case was being discussed in the Supreme Court. And because of his tireless effort, I think a lot of changes have come forth in the legal process, which I'm not going to describe. He will do it for us in the next hour or so. So with that, I think, Dr. Mani, would you like to introduce your presenter? Yeah, Dr. Jha.
Sanjeev is a very enthusiastic upcoming young intensivist. He completed MBBS from Rajiv Gandhi University of Health Sciences in March 2012, and then pursued Masters in Emergency Medicine and from Kokilaben Dhirubhai Ambani Hospital. He has worked with some big names in critical care. Praveen Amin is one of them who he admires and he has taken after as a model. And he has pursued CTCCM. He pursued Certification Critical Care Infectious Disease course. He recently won a few prizes organized by the ISCCM. First prize in quiz, UP, UK, ICCM state. He also won in the ISCCM, I remember. You know, in our 25-year celebration, he won a couple of prizes there. And he is co-authored a publication. So the big, the big world beckons him. He is there at the threshold. I'm sure he'll make his mark. Yeah. Okay, we go on to.
Yeah, thank you, Dr. Mani and Dr. Mehta.
Yeah.
I think, sir, end of life is the issue, is the need of the day. And combining it with palliative care, I think that's the way forward to look at it in both acute and chronic medicine, in the chronic care of these patients. Unfortunately, it also tells us one thing, Doctor, I think it's a philosophical question, is in terms of what is the quality of life which we want, and do we want to prolong the death, or do really we want to put the people back? I think that's very, very important. And as we have been discussing, the Government of India is trying to come up with the guidelines on it to facilitate the financial burden which is breaking the back of a lot of people, to how to get out of it, and ensuring it that ethical, empathetic, passionate, compassionate care can be provided to the, not only to the patients, but also to both care providers, caregivers, and in the process, care providers also tend to get helped mentally and also physically. I think Dr. Mani will agree with me. And that is very, very important. And finally, I will just want to say, before I hand over things to Dr. Mani and to Dr. Jha, is that doctors take death as a defeat. They must remember that death is inevitable, and that is the eternal truth. So we need to accept it with the humility, we need to accept it with the grace, and we need to ensure how we can help family at that tender time when they have a difficulty in deciding for their loves and dear ones. And sometimes the love and dear one forces us to continue with the care to which we don't know how the person is feeling. And probably, I think we need to understand that sometimes in love and compassion, we tend to go far and causing a lot of misery to the individuals. So I think with this background, I hope my colleagues and my friends agree with it. We go for it. Critical care is to bring back people back on their feet, back on their health, not to prolong the agonization or the death. With these words, sir, it's all yours.
Sanjeev, let's have the presentation straight away.
Okay, sir. I'll share the screen. Good evening, everyone. My name is Dr. Sanjeev Jha. Dr. R.K. Mani sir has introduced me. I am working as an intensivist in Yashoda Super Specialty Hospital, Kaushambi. In the past, I worked in Kokilaben Dhirubhai Ambani Hospital, Global Hospital in the liver transplant unit, D.Y. Patil Medical College and Hospital, Bombay Hospital, and Dr. R.N. Cooper Hospital. End of life care needs a lot of light. I have made my presentation in an animated format so that the colors should be there even in the end of life care as the beginning of life. So I'll begin with the presentation. 69-year-old female presented to the ER with complaints of multiple episodes of bilious vomiting, with abdomen distension and discomfort, breathing difficulty, and severe generalized weakness and nausea. These all symptoms were there since last one day. On detailed questioning, she told that she was all fine one day ago. Since one day she had this greenish color vomitus, which was persistently coming out from her tummy. She had persistent nausea with abdomen distension and discomfort. She also had breathlessness because of this abdomen distension, which was lasting since last one day. Uneasiness was there. Retrosternal chest discomfort was there. Bilateral lower limb swelling was also there since last 1 month. Now, on detailed history, she also told that she was diagnosed with this periambulatory carcinoma 2 months ago, and biopsy was also done for the same She was diagnosed with this adenocarcinoma. PET CT was also done 1 month ago, which showed metabolically active conglomerated lymph nodal mass in the peripancreatic region and metabolically active paraesophageal and abdominal lymph nodes. There was also diffuse FDG uptake in the cecum and the ascending colon. She had received chemo. Total 3 cycles she had received 1 month prior, but she was not compliant with the chemo. So last 1 whole month she had missed her chemotherapy, and now she had presented to the hospital with these complaints. She was on multivitamins, painkiller, and ursodeoxycholic acid tablet since the last few days, 2 days basically. In the chemotherapeutic drugs, she had taken carboplatin and paclitaxel 1 month ago. On general physical examination, this lady was all conscious, following commands, moving all 4 limbs, protecting her airway. She had pallor, she had icterus, she had bilateral low limb pitting edema. She was slightly tachycardic. Her heart rate was around 119 but regular. BP around 120/70. Respiratory rate of 26 per minute. Febrile. Her sugars were around 130. On room air, her saturation was around 90. We had started on O2 at 2 liters. On that, she was maintaining sats around 98%. On systemic examination, there was decreased air entry in the bilateral basal area. The abdomen was soft but distended, quite distended. And she had generalized abdominal tenderness. Bowel sounds were present. She was slightly tachycardic. GCS around 15/15. All peripheral pulses bilaterally equal and well felt. So at this point of time, a lady, 69-year-old, coming with a periampullary mass, not compliant with the chemo, now come with abdomen pain and multiple episodes of vomiting. What are our differentials at this point? Can anyone answer? So these were our differentials at this point. Bowel obstruction was the first thing, because I was thinking that if the mass size is growing, it can obstruct the bowel, it can obstruct the surrounding structures. Abdominal perforation, acute pancreatitis, acute myocardial infarction, obstructive uropathy, acute gastritis, or pneumonia. What investigations would you like to send? So we had sent all these investigations, CBC, LFT, renal function test, liver function test, cardiac markers, lipase and amylase, procalcitonin, D-dimer, PET blood culture, urine routine and culture, chest X-ray, ECG, blood gas, 2D echo, ultrasound of the abdomen pelvis, and bilateral low limb Doppler. So the 2-point ultrasound was negative for DVT. We had done an EFAST also. There was mild pericardial effusion. Okay, ascites was there. There was bilateral pleural effusion. 2D echo was showing EF of around 50%, no regional wall motion abnormality, but just mild pericardial effusion.
Dr. Jha, may I put a question to you here?
Yes, sir, please.
Obviously, it's looking at it. Now, obviously, you have come with a list of differential diagnosis.
Yes, sir.
We know it here that person had a diagnosis of periampullary carcinoma. And what is very interesting is in this case is you talked about bilious vomiting, etc. So bowel obstruction does come to there. Now, my only question to you here first is in terms of differentials is, was she having a significant jaundice or not? That is point.
She was having a significant jaundice. Yes, she was icteric.
Yes, she was icteric. The reason is also sometimes we tend to get if there is a jaundice and suddenly it disappears, and then you later on come up, especially when sloughing is there, and then you tend to have what is described as a silver gray scale, silver gray stools in it. If I may, I hope you agree with me. Now, looking at it, obviously, this is a list you have talked about. In terms of differential, that's what we look at in an OSCE evaluation.
Yes,
but looking at a bilious vomiting repeatedly and a consistent pain pattern, how worthwhile it will be for us to consider acute myocardial infarction at that point? I know
So I would always keep acute myocardial infarction at a later stage. And this will be one of the last diagnoses which I would keep. I would always think in terms of some bowel pathology at this point of time.
So probably we will be having a bowel obstruction. That is one of perforation.
Yes.
You may think in terms of
Yes.
pancreatitis occasionally can
Yes.
rest all things probably more of a theoretical thing
Yes, sir.
rather than a practical.
Yes, sir.
Now, next, let's go to the next one now. And then the next slide, which you talk, which now, again, my question to you is obviously with the differential diagnosis, you have asked for it.
Yes.
Now, when we know that person has a peripampillary carcinoma, we have details about it, and all again showing FDG positivity in the colon as
Yes.
well as the cecum. And also you're saying she has received chemotherapy in the
Yes.
past. Now, how do you like us in this sort of a patient for go with the all battery of tests as a first line, or it should be escalated gradually? That's my question. I'm nowhere I'm doubting it as a part of a discussion for our audience that
So
you
till
will like.
now, this is the initial presentation when she has come. She was not compliant with the chemo for the last 1 month. She had not followed up to the hospital. So in this 1 month, she could have multiple things because she's not followed up. Yes, one assumption was that the mass size would have increased, but the features of pancreatitis was also there at this point of time. We also want to rule out any cardiac pathology in her. Okay, and at the same time, whether she's got some infection in the abdomen or not, for which we had to send the cultures.
That I agree. Because if I look at it in general, it looks like a whole laundry list of investigations which one
Yes,
can
sir.
do it. So
Yes, sir.
being in as a medical teacher also, the question is as an emergency physician upfront, I need to know what I'm dealing with. And when we do this sort of a thing, I think it is extremely important for our audience to know it. You need to keep your differential diagnosis in mind.
Yes.
And then you take in account, I will be far happier doing a electrocardiogram, seeing it, whether it gives me an idea, sometimes may not. Then I would like to go for the CKMB. Similarly, I would like to look, she has a bilateral pedal edema, and
Yes.
there may be a dysfunction renal in this patient. So NT-proBNP will not give us any additional value
Fine.
because there you will see it. Because that's the point I'm making as a part of a discussion, though I know
Yes,
it is
sir.
not a part of it. If a person is a fever, then obviously blood culture paired is very well said.
Yes.
And same thing is true for the urine routine and culture, because we have to be careful what investigations we are ordering, though we can have anything. But I think we need to have a little more selective viewpoint. It's a personal view.
Yes.
I'm not against it, what you have done it. But
Yes.
so you escalate it as if need
We
be.
could at this point of time minimize the investigations which we had sent. That could have been
Right.
done.
That's fine. Ultrasonography is fine. Bilateral lower limb venous Doppler is absolutely perfectly fine. One agrees with the X-ray and the blood gases. And obviously, continuation of that is in. Sorry, it's to make a little more discussion rather than that's why I put that point.
Yes, yes. We actually could be much selective with the investigations at this point of time also. So these were the investigations. These are the results of the investigations which we had sent. There was bilirubin, which was raised, total being around 7.9, directing around 6.1. ESR was raised, around 84. Liver enzymes were raised. GGTP was raised. D-dimer was slightly raised. NT-proBNP was 2464. Lipase and amylase both were raised. The cardiac markers were negative. Blood gas didn't show any acidosis.
Again, can you go back to the previous slides? Because when we are looking at in terms of it, when you see the blood gases, you have a 70 of PO2, which is not normal.
Yes.
This means there is a hypoxemia is there.
Yes.
We define mild, moderate, severe. So when the severe is come, then you take it as a respiratory failure. It may not quantify for respiratory failure, but this is what it is all about. And secondly, you also must remember when you're talking about here, bicarbonate is fine. I know we need to look at other factors. If you see the PCO2, it started going a little down. So there is some evidence to suggest there is a hypoxemia, and the pH has started going up. Probably with bicarbonate, there is some evidence to suggest that there is a respiratory alkalosis started happening. It's just as a part of it. And obviously, you have an extremely deranged dysfunction, and GGTP is very high, showing it the nature of the lesions. In fact, this is
Disease.
an obstructive or infiltrative, you tend to see it high. But what is interesting is that your albumin still is reasonably okay, and same with that. And obviously, you are very rightly said, D-dimer and amylase and lipase is high. Please.
Yes. This was a chest X-ray of the patient. So there is, you can see also a PICC line which was inserted, okay, which can be visible in the X-ray. This was inserted during the chemotherapy, which was not used by the patient. We had done the USG of the abdomen and pelvis. So in the ultrasound, the gallbladder was overtly distended. The common bile duct was dilated with 60 mm. Intrahepatic biliary radical dilatation was also seen. There was multiple nodal enlargement in the abdomen, the largest measuring around 33.3. Pancreas also showed an irregular heteroechoic mass lesion measuring somewhere around 7 into 5 centimeters in the head region. The main pancreatic duct was dilated. How do we manage the patient? We have seen there is obstruction, and we are aware this lady is having mass in the periampullary area. How do we manage this patient? So we had given her initially symptomatic management, IV pantoprazole 40 mg, IV ondansetron 4 mg, ceftriaxone was also started, and metronidazole was also started for her. We had started her on her normal saline. Tramadol was given for pain. She was kept nil by mouth. Ryle's tube was inserted. 1500 ml of bilious Ryle's tube aspirate was present. RT was kept on continuous aspiration. After the RT aspiration, the discomfort was much better. We also seek references of the gastroenterology team, the gastrosurgery team, basically the oncosurgery team, and medical oncologist reference was also sought. We admitted this patient in medical ICU. How should we proceed further? A lady with obstructive jaundice, periampullary carcinoma, having multiple episodes of vomiting. How do we proceed further? We planned an upper GI scopy and ERCP for this lady. This was our plan, because we were anticipating that this mass is obstructing somewhere at the ampulla of vata, and because of which she will be probably having this obstructive jaundice. But when we did a scopy, there was a large periampullary growth. You can see the growth here. Okay, they could not cannulate the CBD. At the D2 level, the growth was quite big, and they could not cannulate the CBD. So this ERCP could not be done for this patient. So NJ was inserted here. So after the NJ insertion, patient felt better. We could give the feeds, but the biliary tree obstruction was still there. What should be done? Percutaneous transhepatic biliary drainage was done with CBD stenting. We had involved an interventional radiologist at this point of time. We did a PTBD, and then the biliary drainage was done with CBD stenting was also done at this point. Even after draining the fluid, even after draining the biliary tree, this patient was still having breathing difficulty. She was still a little breathless. Her respiratory rate was around 24, 26, and she was still hypoxic. What should be done? We did an HRCT chest of the HRCT chest for the patient, also a CTPA, and also a CCT whole abdomen. So this is the HRCT chest of the patient. There was bilateral basal atelectasis. there was bilateral minimal pleural effusion at this point of time. CTPA, no evidence of pulmonary embolism. In the CCT whole abdomen, here we could see the mass. The mass was compressing all the nearby structures, which was all around. We could see the drain, the CT drain. So in the CCT, there was an extensive conglomerated necrodal lymph nodal mass involving the gastrohepatic area, periportal, peripancreatic, portocaval region, and the mass size was 71 into 57 mm. This lesion was encasing all the major structures, the common hepatic artery, the gastroduodenal artery, the left gastric artery. The mass was also extending up to the IVC. There was portal vein thrombosis. Pylorus and the antrum of the stomach was compressed. The first and the second part of the duodenum was compressed. The pancreatic duct was dilated. There was features of acute edematous pancreatitis. Patient was initiated on anticoagulation and a low-dose diuretic at this point of time. Within 5 days, patient was symptomatically better, hemodynamically better. Saturation still on room air was somewhere around 92. And on 2 liters of oxygen, she was maintaining sats around 97%. Patient was shifted to the wards. After 1 week of ward stay, patient presented to the ICU again with multiple episodes of vomiting, nausea, abdominal distension, and increased work of breathing. RT was reinserted, and again, the RT aspirator was quite significant, around 1000 ml. At this point of time, we knew that this is something to do with the periambulatory CA, because of which she would have landed up in acute obstruction again. So we repeated the abdominal imaging, and during the abdominal imaging, we also took the upper basal chest cuts. So within approximately 8 to 10 days, this lady's effusion, bilateral pleural effusion, increased in size. The mass size had increased. The mass size had actually increased. She was also tapped 4 days ago in the wards, but even after tapping, there was significant ascites around. So the mass size, which was somewhere around 70 mm earlier, it is now 105 mm into 81 mm. Portal vein thrombosis was still there. The compression in the around structures, pylorus and the antrum of the stomach, first and the second part of the duodenum, was much. The pancreatic duct dilatation was more. Initially, it was 4.2 mm. Now it was 4.8 mm, with features of acute edematous pancreatitis, and bilateral pleural effusion was also there, with moderate ascites. Patient was planned for a repeat upper GI scopy. So the upper GI scopy was done, but the mass size had increased. That is why she was again having this recurrent vomiting. After a lot of manipulation, the NJ was reinserted, and patient was advised for duodenal stenting. But this duodenal stenting was just to relieve the mechanical obstruction. In view of worsening breathlessness, patient was initiated on an IV. Pleural tapping was done bilaterally, and also ascitic tapping was done. The fluid was hemorrhagic, exudative. Post-tapping, patient was symptomatically better, but she was requiring an IV with high oxygen requirement. What next? This lady, 69-year-old, periampullary carcinoma, rapidly growing tumor, compressing the major structures, and it is also extending in the vascular region, in the IVC. What next has to be done? We had asked for a multidisciplinary meeting where
I think before we shift over, I just had a couple of questions again, which have been coming to my mind.
Yes, sir.
I hope you won't mind, and Dr. Mani, you will also. probably will not. You see, this is a patient you have very beautifully presented, coming up with the proven case coming to you. And this also shows something very interesting, is that as doctors, what we intend to do, looking at it, that we have done everything, and then obviously gives us a solid ground to talk and go for the futility of care. Now, Dr. Mani, that is what is bringing me up with the new criteria. Will these patients, should these patients where there is a futility of care be actually admitted to? First time I can still agree. Do we still, when you take this patient to the second time with the new guidelines, if they become applicable and we start practicing? What you are doing, MDT, right after this second episode, should not it have been done earlier? Now, this is a theoretical question which I am putting to you, which anybody can come up. And secondly, should this patient should have been readmitted to the intensive care unit? And third is, when we know what are the situation, we're looking at it, the role of multiple procedures in this setting. PTBD is absolutely justified, no confusions about it. Of rest of the things which are there, these are the few questions. I know this is an open debate, open discussion about it, but as a counterpoint, before we go for the multidisciplinary task meeting, which is perfectly right, I say that it should have been done at maybe before the second admission. Now, I'm deliberately asking this question so that we can have some discussion.
Dhruva, you've opened the debate now beautifully. Now, this is the real question, and this is the reason why we used all those criteria, admission, discharge, and all that. But this is as it turned out in the real world. Okay? In the real world, what we are doing these days is not opening up the prognosis and the conversation around it early enough, as Dr. Chaudhary pointed out. That is exactly the point. Without a conversation, without an understanding, what happens is you get a second admission, which in retrospect looks so pointless. So, the case is that the message that we want to convey to all the young doctors and for to the colleagues is, when, in such an obvious case as this, we are not mentioning the prospects, we are not opening the conversation around prospects. Clearly, you can anticipate death in this case. We have not mentioned death. The majority of the cases, you have a gray zone, you see. At the outset, it's not so very clear, and the story unfolds a little gradually. But here, see, story started with poor prospects, and what we were trying to do is just symptomatic treatment. Perhaps it was justified from that angle, but it's not justifiable not to talk about what we are doing, not to set the goals of care. You can tell the family that here we are only relieving her symptoms, her distress, her obstruction-induced buildup of bile and, all this aspirate in the abdomen, and the ascites in the pleural fluid. We tap for reducing the respiratory rate, not for anything else, not with a curative intent. I entirely agree with Dr. Dhruva Chaudhary that we should open up these conversations much earlier and do a reflective prognostication, not a routine, not a very mechanical prognostic. Oh, it's cancer, you know how it is, not that sort of thing. Little more in depth, little more explicit. Do you agree, Dr. Dhruva and Dr. Mehta? Many times we are not very explicit, we are suggestive, we are elusive, but we are not explicit. And that it calls for a better understanding of how to converse, how to convey with compassion, with gentleness, but it has to be what is a fact must be conveyed.
I think very well said, Dr. Mani. I think with the choice of words have been excellent. In fact, to tell the situation, our idea is to sensitize to the people that these are the cases which will keep on coming. As you said, rightly, the first time you have no answer, but you need to take it up. Obviously, it fits with organ dysfunction, fits with in spite of the diagnosis, in spite of that she was erratic with the treatment. But yes, as a part of it, the important point which Dr. Mani you made is that conversation, communication must start early. And as doctors, we must learn to prognosticate, and we must learn to prognosticate reflectively. It's not that 88 chances of probability. First, we can use simple scoring systems, and then on the basis of that, looking at diagnosis and prognosis, we can add to it so that it becomes simpler, easier for us to tell the family, because it takes time for them also to digest. They know what is inevitable, but at the same time, they need some helping hand to support them, to help them to understand the things so that they are better, they are better aware about it to take a conscious decision. Am I right, sir? And Dr. Mehta, sir?
Yes, I think it is important to start the conversation, as Dr. Mani pointed out, earlier than later. I think the first admission itself, if the conversation begins, and I think, and you're absolutely right, Raj, that we don't necessarily have to talk in terms of percentage, that the chances of survival is 10% for the next 5 years, and things like that, which will probably should have come earlier with the oncologists sitting with them. But I think it is important to start gently leading them to where the futility of the care and what you need to do to make the patient comfortable, pain-free, be with the family, and so on and so forth. I think that is important to begin early.
So what has been seen in studies is that the oncologists talk about death and the foreseeable mortality only 30% of the time. Oncologists, when they see cases like this day in, day out, and you see the gastroenterologists who have such smart procedures now, they hardly ever talk about it.
Mm.
Okay. So
This is true,
this
sir.
is the fallout of the culture of advancing technology and increasing capability to manage things. But we need to match that with improving ability to convey what to expect, and in a balanced way, without taking away hopes, but at the same time conveying the truth.
Very well said, sir.
Very well said.
I just wanted to bring that issue because before we go up, so that that was the reason. I think both of you have said very nicely, sir. And let's move ahead now. A multidisciplinary team, which again
Okay,
tells
sir.
us that critical care is not an individual person; it's a team, and where we need to have a different stakeholders bringing it up, trying to build up a consensus, so that the doctors don't, or the nurses even don't talk. The medical team as such should not talk differently. That is very, very important, because people look for those things. I say something, you say something. So I think that will be explained further by Dr. Jha. So I'm very happy that they called for the multidisciplinary team, and our colleagues should learn from this, that whenever in a trouble, it's always good to have a teamwork which works. Dr. Jha, please.
Yes. So this meeting was called. This was interdepartmental meeting first, where the medical oncologist, the oncosurgeon, the gastroenterologist, and the intensivist sat and discussed regarding the prognosis of the disease. This was an unresectable tumor which could not be operated, and a rapidly growing tumor which is metastasized in all the major structures in the abdomen. As per the oncologist, the prognosis of this disease remains very grave, where he cannot find any window to give chemo at this point of time. Secondly, she has responded very poor to the initial chemotherapy. Duration of the treatment, if on chemo as well, was discussed, and it was told that this chemo may continue till the end of life. So a combined decision was taken, and we had planned to transition her to palliative care. We had called the relative. This whole discussion was then done in front of the relative, and a shared decision making was done with the relative. The relative was made to understand regarding the depth of the disease, regarding her clinical condition, regarding her metastatic disease. Relatives were already aware of what's going on, and they didn't wish for any aggressive line of management. They opted for comfort care. This lady had pain in the abdomen, for which we had started her on low dose
Dr.
opioid
Jha,
infusion.
I will just like to hold you here. Can you go to the previous slide, which you said? Yeah, and the previous one. Previous one. Yeah, multidisciplinary. Dr. Mani, here I would like to put a question to you. And now you being the expert in it, and no. Come back to that same slide. Shared decision making. Yeah, that's. Uh,
This one.
previous.
Okay, sure.
Sorry, keep it here because this is the basic slide on which is the thing on which everything in the future depends upon it. So here I would like to be enlightened by the viewpoints of Dr. Rajmani. That said, when you talk in terms of multidisciplinary meeting, what sort of a cautions you take when you decide that we need to start talking about it, these decisions? Obviously, it's a case where you are seeing malignancies of fertility care is much easier for people to accept, but sometimes there could be a acute illness coming up suddenly bolt from the blue, then it becomes a little more challenging. So, sir, how you use your experience and when you decide, when you're prognosticating, etc., the time, obviously you cannot give us a black and white, but how you initiate, how you look into it, and how can you help us thinking in terms of it, which can guide our colleagues who have joined us.
You see, as you observed before, Dhruv, we need to have multidisciplinary family meetings early. And Yatin also said the same thing. We should have it early, particularly, in a very obvious case like this. We should have the gastroenterologist, gastrosurgeon, intensivist, sometimes an internist is involved. They should be talking about how best to manage this patient from maybe day one or within first 2 days. The recommendation, the evidence-based recommendation communication is even before non-beneficial course of curative treatment becomes apparent. You should start to build a conversation, build a rapport, and then within the team also, within the care provider team, there should be an understanding between each other and contribution to each other's understanding. So, but what happened was we did it a little late, I agree. But this is what, firstly, there has to be a consensus within the team, right? Firstly, we must speak in one voice. I think Dhruv mentioned this before. That when we talk to the family, they should have the assurance that enough thought has gone into things. They've considered options, and they are giving us a distillate of what they have understood, rather than just merely telling a physiological features of what the pulse is doing or PP is doing. So they've got an overall understanding of what they are doing. That's how our within discipline, interdiscipline meeting initially focuses on these issues as you've enumerated. What is the program? What is the median survival time? When we talk to oncologists, they don't tell us, but we have to ask them, quiz them. What do you think is a median survival time? Best case scenario, worst case scenario. Right? If you pin them down like this, then we might get truth somewhere in the middle, right? Best case, worst case. That's a very good approach. Then, what is the quality of life with treatment, without treatment? So we got two things. One is survival, one is quality. Both must be discussed. Very often, survival may be a little long with some intervention, but quality may be poorer or, not acceptable to the patient. So that has to be understood. Then, the palliative care only option, because palliative care is there throughout critical illness. It's not just only when end of life is near. As a patient put on a ventilator, you start analgesia and sedation, don't you? Okay, and you start right from the beginning to minimize the chances of dementia, delirium. So palliative care begins. But here we are talking about palliative care only option. Okay, I'll stop here to get the inputs from our teachers, Dr. Chaudhary and Dr. Mehta.
See, I would like to only add one thing. I think it has been extensively and nicely covered by both of you. I'd just like to point it out. It is better to have an interdepartmental meeting without the relatives sitting there
Yes.
first,
Yes.
so that everybody, as you rightly pointed out, is on the same page. Because if they see any hesitation or any difference in opinion among the team members, then they will get confused and they would not know which direction to take.
Absolutely.
I think
Dua,
sir,
your
you
take?
very well said that. And this holds true not only for this patient, this holds true for all patients. Like we see in 80, 90 years, people coming with the strokes, they're looking at, or sometimes people younger also, because family always tries to find out a ways and means, though in heart of heart, they also know it. So that's what I have realized, as Dr. Mehta said it, and you have also said it. First, we need to be clear in our head what we are looking for, where we are heading for. Because unless or until we are not clear in our mind, we need to be truthful. But at the same time, when you are communicating with the family, once consensus is built up, if there is no consensus, please don't talk about it. That's all I will say, sir. So that creates much more bitterness among the care among the family. I hope you will agree, Dr. Mani. But once we have a consensus, only then we should talk about it. We relook at
I
it.
entirely agree. It gives confidence to the family if they see a group
Yeah.
of people coming to an understanding, and speaking in one voice. It gives them a lot of assurance.
And sir, also I have realized, and like to have both of you's viewpoint also, is that nurses help us a lot in terms of it because they are spending much more time with the patient than us. So they also help us in prognostication, and enough evidence is showing that nurses are far better than the doctors, except the experienced senior people in terms of prognostication also, sir, on the clinical side, in the critical care. That data is there. So it's a very important, rich resource with us. You as a leader, we have to talk, as a physician, as a path, we need to talk about it. So what I have realized in my own practice is that I start exploring through my nurses, sir, what the family is looking for, what the family is asking for, what are their expectations. Because when I'm taking a decision making, I can only have a shared decision making if I understand the other person's side. Because otherwise, what I'm trying to do is I'm trying to put my viewpoint on them, which sometimes may not go well with our system. We're talking about the evidence, but a lot of people go with their social, cultural, religious background, which as a physicians we don't take into account. So that's what we look at in the multidisciplinary meeting also. For me, as a, let's say, as a pulmonologist, outcomes we look at in terms of years, sir. The same is true for you also. But when it comes to the oncologist, for them, 3 months is a big time, sir. 15 days is a big time when you talk to them. Because I feel very uncomfortable in terms of prognostics. I'm not doing it because otherwise the specialty brings you down in terms of mental health of the person who is providing the care. So these are the things which I look at it, and then I go ahead with it. And I obviously, definitely, as you have said, what is the quality of life? It is the longevity or it is the quality of life. That is what I have realized, sir. Giving an example, within my own family, an elderly person had an ARDS. He improved. Then he worsened. And on the insistence of immediate son, who himself is a doctor, put on ARDS. When he opened up, he himself was the patient who was it. He said, stop all this nonsense, I'm in pain. So the point I'm looking at is I'm giving this very example of that first team should have their viewpoint, because I've realized sometimes the doctors itself says, no, so this is not done. But we need to look at this as a precious resource. We are going to create more and more financial. We are going to give physical and emotional trouble. And that's how I look at it. I don't know I'm right or wrong, but that is the way one has evolved with an experience.
You see, I couldn't agree more. You see, you can have two different perspectives on the same situation, and that is the reason why we must talk. And talking means navigation, negotiation. It is not my way or your way. It is not black or white. Particularly in these sort of decisions, you feel your way into the decision. You are also watching the patient. As you see, as the story unfolded, you could see with even more clarity that there is nothing going for the patient. But which At the outset, some people may be tempted to believe that, it's still modifiable. So what I'm trying to say is this kind of navigation negotiation begins within the team first. As Dr. Mehta said, first set your own house in order, then you talk to the family.
Very
And there is
true.
some kind of clarity. And you offer a proposal. You don't say with dogmatism, okay? You say to engage in a particular perspective or conversation, you begin to say that this option is also there. Its option is there for you. It is not something that we believe and we thrust it upon you.
So sometimes what one has observed before we move further is putting it up that in Indian context, there number of people will come and ask about it. What will happen, how to happen, what will there. So what is your take that there are a number of this, or there may be a survey decision maker, maybe a legal here, maybe somebody else. A lot of
Sure,
people
I'll
start
first listen to
asking for it.
Yatin. I think he has something to say. Then we will address this question.
Yeah.
Yatin, you had something to say.
No. I was just saying that many times the family wants you to gently lead them in a particular direction. They are looking at you for some direction when they are in trouble, and I think that is your job that way to sort of suggest, not force them, just suggest that if it was my mother, I would do this, something like that, which they take it quite well, and you need to give them some time to mull over it, discuss it among themselves, and then get back to you. So you say, okay, the decision doesn't need to be taken now. Please sleep over it, discuss among yourselves. Let us meet tomorrow. And then they many times they want me to indicate, I mean, that I would not do this sort of aggressive, unnecessarily prolonging misery and death. And I also sometimes mention it to them that, see, it is our selfishness at times that we do not want to lose a parent or a sibling or whatever. But I think it is not in their interest because they would be suffering. And I think the quality of death is as important as quality of life or longevity. So I think many times, most of the times, they do listen to what you say and how you lead them. So
Absolutely. I think that is the kindest way to approach this because, Dhruva, much that there is a legal aspect to this, but the heart of the matter, see, the crux of the matter is the humanity. All right. Patient and family centricity is the crux of the matter. So even if there is a difference of opinion within the family, we can patiently give both sides a hearing, and you may offer your own your own take, as Dr. Mehta says. You can offer your take, your suggestion. It should be a suggestion. It's not some diktat. I think many times we are used to giving diktats as with the curative treatments, but here we can be a little more uh, flexible, open to alternative opinions, and within the family it can be resolved because there are people who are more emotional than others. There are people who are maybe less experienced or less patient. So we have to negotiate through these dynamics. Okay. We have to negotiate through the family dynamics also. It needs time, it needs a bit of patience, it needs a bit of skill. Like any other art and science in critical care, it needs skill. And you get better at it the more times you do it boldly, bravely.
I think well said, sir. And let's move ahead now. Yeah.
So your shared decision making was done where the relatives did not wish for any aggressive line of management and they opted for comfort care. We had started her on low dose opioid infusion. As per pain score, Wong Baker's face pain rating scale was used. We also intermittently used numerical pain scoring to assess the pain, and we had titrated the opioid accordingly. This is the WHO analgesic ladder, where for mild pain, we used non-opioids normally. For moderate pain, where pain score is nearly about 4 to 6, we used to use weak opioids. But where pain score was above 6, we used to use a strong opioid, like morphine. Spiritual care. Here, holy songs were played as requested by the family members. Bedside prayers were done. Priest was also called. Rituals were allowed to do by the family members. They wanted to do some rituals, giving Ganga Jal, so it was allowed. The family members want to be with the patient in the last days. They requested to shift her to wards, so we had shifted her to wards. Liberal visits by the near and dear ones were allowed. The economic burden was also reduced. Basically, the curative treatment was stopped. Empathetic conversations with the patient and the family members was done. Patient was continued with NJ feeds. Patient's wishes were asked and also addressed accordingly. Anxiolytics were given to relieve the anxiety. Of course, the basic laxative we had started because she was an opioid, she doesn't end up in constipation. After 3 days in the wards, patient had sudden episode of bradycardia followed by hypotension and later had cardiac arrest. As per request by the relatives, CPR was not initiated. This is one quote I would like to address here. The end of life care deserves as much beauty, care, and respect as the beginning, which we need to inculcate in our day-to-day practice. Some basic elements of quality of end-of-life care. Care related to the symptoms and personal care. Pain management should be done, being clean, keeping the patient clean, hygienic. Physical touch is very, very, very important. Being prepared for death, knowing what to expect, believing family is prepared. Patients should have achieved a sense of completion, like saying goodbyes, resolving unfinished business, recognizing one's own accomplishments, being treated as a whole person, maintaining dignity, maintaining the sense of humor, relating to the family, society, care providers, coming peace to God, peace with God, it's very important. Being able to discuss personal fears, including dying and death, trust and comfort with the clinicians and the nurses. It's very important. My take home message from this: for patients on palliative care, we should treat and care more through the heart than through the mind. Dr. R.K. Mani sir, he is the father of end of life care in India. He is one of the pioneers, one of the ex-ICCM presidents, which I admire the most. I remember there was one patient who was having metastatic carcinoma lung. There were a lot of consultants who used to ask me, how is the prognosis, what is the prognosis? But only one person had asked me, ask him what are his last wishes. And he was none other than Dr. Rajkumar Mani sir. I am blessed to work under him, to be under his guidance, because I think he remembers this patient name as well also. And everything in end of life care, it has to touch his feet first and then go in the market. Then go international.
No, that's enough. We proceed.
Okay, he is one of the biggest pioneers in end of life care in India. These are my references: ICCM, IPC, ULC guidelines in 2014, January 2023 Supreme Court judgment for withdrawal, withholding, and advance medical directive. ICCM, IPC position statement 2014, which is still in press and will be published soon. this is the hand of Dr. R.K. Mani sir, which is putting seeds in the ground so that the end of life care is given a lot importance. Thank you very much.
And thank you, Dr. Jha. Dr. Mani, now I have a couple of questions about it. Obviously, this is one part technically, but one of the things which is hindering to us in terms of implementation of end of life, the guidelines of Indian society are there for a long time. And then we are working with the Indian Association of Palliative Care guidelines are there for a long time. We are coming with a new document. And now Government of India is also trying to come up with it. So in this term, when we are sitting here till the things they come up, how do you think that we need to start these services? If I put it quote unquote, end of life care services or process in the intensive care unit, keeping unique legal framework of our country in which it has been now conditionally allowed?
See, very important question, and we have been mulling over this for the last 20 years, as Yatin and Dhruva know. So, what were our barriers, to
Just hold on,
progress?
sir. Can you stop sharing so that we can keep on seeing Professor Dr. Mani?
Quite right.
Please.
You stop
Please.
sharing, Sanjeev.
Yes, sir.
So,
And I will also request the audience, we have got both on Zoom as well as on YouTube to please send their questions so that we can put it to Dr. Mani. Sir.
So you see, one of the biggest barriers was that two things, our perceptions. See, we were used to intensive care came a bit late, maybe 15, 20 years later than rest of the world, in a big way. We'd start with in the 90s here, in the US, it was there in the 70s, early 70s. So we were more caught up with the romance of critical care, right? I mean, to all those dramatic recoveries. Previously, we were not used to such things, used to treating people so critically ill and bringing them out. So it was a big joy and a surprise and all that. So we were caught in that. And so we were trained like that. Always try to resuscitate, rescue, cure. We didn't know any other perspective. Even in the West, it took a bit of time to penetrate. Somewhere in the middle of 70s, in the 50s, it all started CPR and intensive care as we know it today, organ support and all that. In the 70s, they realized that many people don't go anywhere and they get even worse and there are more problems than they solve. But to us, this perspective has come a bit late, and we were less eager to take it up than the new technologies. We are very eager to pick up a laparoscopy, bronchoscopy, or ECMO, but we are much slower to pick up a concept. Okay, concepts such as autonomy or beneficence. Either the bioethics developed in the early 80s, and it's still not fully there in our country. This is one barrier. You see, the lack of awareness of the needs of the dying, I would say, or the need to create a culture of any ethical climate in the ICU, where you say this far, no further, or you cast every new intervention into some kind of an ethical boundary. Then came the legal fears. We have a double problem, double jeopardy. Most of our medicine, involving critical care was in the private sector, right? Your income was linked to your procedures. On the other hand, you were also very vulnerable. You're very vulnerable legally. You had this Consumer Protection Act and other things, and we were also had a gut feeling always. If you get caught in a legal thing, it's very difficult to come out of it. Okay, it's not it's a very slow process, and you may spend another 20 years fighting. So these two fears combined for us to not at all allow a different perspective to emerge. So we realize that even if a lot of us understand why we need it and we understand the needs of the patient and family, We are not going to have people buy into it in a big way. See, the ISCCM made its first position statement in 2005, and nobody had heard of anything like this. Okay, no other professional society, nothing in the society, nothing in law was there at that time. It was a complete vacuum. So we had the position statement, we had all these, pathway to end of life decision making right there, and it's only got vindicated today. But we had nothing in law. So there was a little legal evolution we have witnessed in the last, since that time, 20 years. Aruna Schonborg judgment came, it was mainly centered around vegetative state, so they could not understand the perspective what was happening in the ICU day-to-day care. So they said you have to go to the High Court. It doesn't make sense, okay? But they, at least in principle, they agreed that so-called passive euthanasia is constitutionally valid. But they didn't want advance directive and all that. So we had to fight for that. ISCCM impleaded in a case called Common Cause. Common Cause was initiated by a NGO in 2005, saying that the Indian citizen has the right to execute a legally valid advance directive. But then it was shot down by the then Law Commission of India, saying that it's risky, it will be subject to misuse, and the same position the second Law Commission report in 2012 also took. They took the position of Aruna Schonborg, and they said advance will not allowed. So we had to fight for it. So we impleaded in 2015. In 2018 came the landmark judgment of Common Cause versus the Union of India, which said an Indian citizen, by virtue of Article 21, the new interpretation of autonomy and privacy, is entitled to all this. Advance will, entitled to refuse treatment, which includes withdrawal withholding. So for the first time, there was such a joy. I was there in the in the court at that time, and we couldn't believe it. We were pinching our skin. My colleagues and I, who were there in this campaign. But then they undid all that in the procedure. They made a three-tier system, which involved the judiciary, the magistrate, it involved the collector, district collector. My God, if the judiciary and the, the bureaucracy has to control us, okay, they decide whether a person should be, the care should, treatment should be withdrawn or not. We are going nowhere. So obviously nobody utilized that provision. So the ISCCM and the Vidhi Center for Legal Policy, which is a legal think tank, which even works with the government in many, many cases, we together appealed. I know, ISCCM appealed, we are the appellant, I represented the ISCCM. We appealed to the Supreme Court to simplify this process. And Vidhi Center represented us legally. And Elicit, which is another a task force which was formed by three societies, critical care, neurology, and palliative care. They gave us support. Lo and behold, appeal was done in 2019. It came for hearing in November 22. The biggest barrier was, at that point in time, the Ministry of Health was not convinced that it needs to simplify this procedure. As always, they were hooked on to the idea that the profession is not trustworthy and we cannot let them be ungoverned, so to speak. So they always harped on the possibility of misuse, forgetting that there is a great deal of misuse in our midst at the moment by using excessively all these interventions. And it is already the consequences we are witnessing every day. But that misuse was ignored. But the other side was exaggerated. Okay, this is what happened. So we had to talk to on the one side, the government, on the other side, appeal to the court. To our surprise, both the government and the court agreed on one thing. They said the previous procedure is unworkable. We said, really? I couldn't believe my own hearing. The court said it's unworkable, we accept, because the the physician team is saying that this is unworkable. So the court said that the appellant should sit with the Ministry of Health and come to a agreement, compromise. Both have a perspective, and then whatever you agree, we will endorse. My God. So we had to bite the bullet. We had to speak to the Solicitor General. You know, it took a year, it took a long time to even get an appointment with the Health Ministry because the COVID came in the middle. Ultimately, what happened was they agreed that we don't need the district collector and magistrate and all involved. We thought we had crossed. Okay, we had crossed the Rubicon. But they said, no, there has to be some representative, okay, appointed by the CMO who should be part of this. So we agreed on this two-tier system. There will be a primary medical board of 3 physicians. Previously, Common Cause said there has to be 3 physicians. They specified the specialities, which included even psychiatry, right? All of them, psychiatry, neurology, cardiology, must have critical care experience. You know, so it was again unworkable that sense. And of 20 years experience. My God, you'll never find these people. So we simplified that. That any physician, okay, involved, any physician, subject specialist, they call it. Okay. It means it is left open what subject specialist means. Okay. It does not mean any particular specialty. Okay. It includes all specialty. So we came to that 5 years and 3 physicians. It has to be collective decision. So primary medical board is constituted by the primary physician, admitting physician. Number 2, the intensivist. Number 3, any other physician, any other specialist involved in the case. This is the natural way in which we care for the patient in an ICU. You agree with me, isn't it, Yatin? Huh? In any case, you have 3 or more people involved. So the interpretation of this is, and these people are involved and they confer and they constitute the primary medical board. Okay, primary medical board doesn't require the whole of the ICU team to be there. One intensivist, then it has one, say there is a neurologist, and then there's a primary admitting. This is enough. So you have the primary board already made. You confer within yourself, speak in a single voice, then you talk to the family, give them the options. If there is a consensual, agreement, then you must have a secondary medical board. This is where the whole of the confusion and problems are. Secondary medical board is 3 other physicians, independent, again with 5 years experience, again subject specialists, one of whom should be appointed by the CMO of the district. Here again, the court, you see, I was there throughout this proceedings, and many times we were meandering into regions which looked very dangerous to me. So I had to somehow get a word in, okay, even though nobody allows you to speak. Nobody other than the lawyers get a word in. And you have a big barrier of communication between lawyers and doctors. Somehow, there was Dhwani Mehta, brilliant legal person, lawyer of the Vidhi Center, with whom we worked for 5 years. We had loads and loads of conversation by which we have come to a common understanding where, that big barrier between doctors and lawyers no longer existed. So we could speak in one voice. We could prevent the court from adding any more barriers, okay, and leave certain questions open. It does not say that you have to have that CMO appointed doctor from outside the hospital. It may be from within the hospital or from outside. It doesn't say which specialty. Subject specialist includes everything. Okay.
No, but that doctor has to be recommended by the CMO.
One doctor.
Is approved. One doctor is approved by
one
the
doctor,
CMO.
not all 3. Two people
Right.
from the hospital, one person empaneled by the CMO.
Okay.
It doesn't say whether you can have a standing panel or you have to make an ad hoc panel. No,
Uh-huh.
there's no word on that. That is up to you.
Yeah, yeah.
Number two, very importantly, we put in a word saying that majority of the decisions are made within the first week in the ICU. Okay, it doesn't take months and months like Aruna Sharma. So they added another caveat there. They have to give their opinion in 48 hours, within 48 hours. So within 48 hours
admission.
means it could be within a few minutes also.
No, of 48 hours of admission to the
No,
ICU.
no, within 48 hours of the primary
team
board
side.
requesting them.
Okay, recommend. Okay, okay.
The
So this
primary
basically is the
board
direction to
and the
the
family.
CMO,
Yeah.
that he has to
Right.
empanel that person within 48 hours. Don't keep on lingering it.
Right.
No, they don't say they have to appoint. They said their opinion has to, the secondary medical board opinion must come within 48 hours.
Within 48 hours of the primary board. Yeah.
Yes. So they understand that time sensitivity. For the first time, we got to know the time sensitivity. Now I'll wind up quickly. So this is what we have. A primary medical board, a secondary medical board. Once the secondary medical board endorses this, you can implement your withdrawal and withholding. You have to inform the magistrate's office. We have confirmed at that point in time, you can even see them again. They were all recorded. That time, it was online recording. And many of my colleagues saw it online also. So you don't have to wait for any approval or endorsement. You only intimate. This we have confirmed also. So what do we have now? We want the CMO to be able to empanel some doctors of our hospital as the appropriate authority empanels a brain death committee. They appoint a brain death committee. You have a standing. You have somebody appointed for counseling in transplant. So the issue is you can have a situation like that. So the court ordered that this information must be sent to all districts, 600 districts. They had added this. You have to send. As it happens, no notification has been sent to any of the districts, as it usually happens. There is a gap between what the Supreme Court says, and by the time it comes to implementation, it takes a long time. So this is where we have to catalyze this whole process. How do we catalyze? We remind people, to 3 state governments. I and my colleagues have written to the health ministry. Myself for UP, we have sent, and I have also met the health secretary. Their final decision is pending. All they need to do is notify the CMO, right? They send them this judgment and what the role of the CMO will be. And Dhwani has also drafted a template as to how to go about appointing doctors, either outside your hospital or within the hospital. If it is within the hospital, there are big hospitals like Medanta, like your hospital or mine, where you can have a panel of doctors already existing, so you don't have to search far to create a SMB. And this has happened also in Odisha. It has gone right up to the health secretary and discussions are taking place. It has happened in Karnataka. I was very surprised to note last month that in Haryana, they have sent the notification. First state, it came in the newspapers. The Qatar government had sent the notification with attachment of the judgment, saying that CMOs should be notified of the judgment. And they've only talked about advance will. They haven't talked about withdrawal withholding. Unfortunately, they've only done a half job. But at least
that's a step forward.
Yeah, first state, you have to be proud of it.
Yeah.
First state to do it in this country. So whereas UP had the chance, they have missed it. So this is where we stand now. There is a technical resource group Yeah, I'll come to Dhruv and I belong to a technical resource group appointed by the Ministry of Health and Family Welfare, who have asked us, it includes me and 30 others, that, me, Sheila, Dhruv, and many others, you'll be our ISCCM, many members from ISCCM. Now, they've asked us to make a document of an SOP for this end of this withdrawal decision. So this is where what we are proposing, that we will have this sort of primary board and secondary board, and we want the notification as per what the Supreme Court has said. Notification to all the districts,
CMOs.
and then the district CMO empanels some doctors. So I think we are nearing the end of creating this document. It's almost made. And if we can submit to the Ministry of Health, as we did the ICU admission discharge criteria, which were, approved by the government in toto. And there we introduced these concepts. What Dhruv was saying, don't admit people who are so advanced that they cannot have any curative treatment. And similarly, you think you've had an understanding of palliative care only, you discharge the patient from the ICU. And we have also given, there are some conditions in which you still continue to keep in the ICU, but give them palliative care in the ICU. Okay, sometimes it's difficult for symptom control. So you see, this is what we did in this case. In this case, when there is clarity, we moved the patient. Okay, I'll stop here.
A few questions for you.
Yeah.
Sir, this is Dr. Prashant Ranjan Behra. He is asking if there is a conflict between patients' sons and daughters about whether to be aggressive and non-aggressive treatment, then what will we do in such cases?
We talk. We don't take a decision if there is a lack of consensus within the treating team or lack of consensus within the family. See, what I'm saying is we offer an opportunity. We don't force anything on them. And we are also not obliged to institute treatments which are medically not valid. Okay. Supposing somebody is brain dead, but the family wants some brain surgery done, I won't do it. I am not obliged to do. I'm telling you, such a situation did arise in one of my cases.
So the answer, if I summarize,
See, I would
one
second. Yeah, one thing I would like to point it out for the younger colleagues is when there's a conflict within the immediate family, siblings, for instance, I think you should not push for anything. Let them come to a consensus.
Yeah.
Because then, you may be legally also the thin ice in future if one of the child says that, I was bypassed. And so let's not get into technicalities or legality about the legal heir. But if there are 3 children of a parent who's dying, I think all 3 should be in agreement.
Agreed, sir.
Yes, absolutely. And majority of the families, you see, you give them time and a little bit of counseling, they come together with a decision, and that makes them feel good for the rest of their lives also.
So there's a next interesting question. Excellent talk. Is this topic being included in MBBS MD curriculum? Practically, when we teach curriculum, I have been teaching to my undergraduates here, honestly speaking, but that is by choice, not that it is forced on us. But definitely for postgraduates and critical care, we do. Sometimes the patient may deteriorate fast. Now, this is a question now. Sometimes the patient may deteriorate fast, giving them less time to sensitize, giving less time to the medical professional to sensitize the relatives about prognosis. What should we do?
See, in medicine, you have to learn on the job. It is like flying, you can't learn without flying. Okay. So you have to face different kinds of situation, negotiate your way. There is no cookbook. You have to find your way.
Another question by Dr. Behra is, can our technician remove the tube if relatives asked to do this after went off ICU as discharge against medical advice? Dama, no.
My dear, Lama and Dama are not great things to do. Don't be proud of it. Okay. You are neither giving any palliative care to the dying patient, nor getting a harmonious relationship with the family. What are you doing? You're just washing your hands off. and you are just condemning the patient and family to their own devices when they really need you the most. So that is not to be encouraged. I have myself reduced lama in my own practice to zero or minimum by constantly counseling myself that no, you see, you're advocating against it, and you can't allow this to happen in your midst. So lama I take as a
No,
you
see,
know harsh mirror to
see,
my
Dr.
face.
Mani, I would disagree on this point because it is moralistically or ethically right what you're saying. But what does one do? Every day, patients leave a hospital, Lama, because they cannot afford to pay the bills. Now, who's going to pay for it? If I pay for it, I will be starving. I mean, you
Sir,
cannot.
that is a
So that's the practical problem in
Dr.
India.
Mehta, I face the brunt of that. But,
I'll
but,
tell you
but
one thing.
In fact, our administration.
Yatin, you're a very practical person. Now, issue is the issue is that if you talk early enough and offer them paradigms other than just one way, then you are able to be more fiscally efficient. Okay, you may reduce the number of lama, you may not eliminate it. But many people go lama out of frustration because they can't find a way out. Okay, every day they are told prognosis is very poor, yet the tube is hanging, yet they are escalating. Next thing they do is to escalate to even a more expensive antibiotic, or suddenly they say go Sepsivac, suddenly they give Cytosorb, right? When they saying there is no prognosis, right? So this piles up. So part of the financial difficulties they are facing is our doing, our prescription. That is one point. Number two is some ecosystems have created the way to reduce their financial problem. Okay, we have Gangaram. Okay, they do transfer to free area. We have CMC Vellore, where they have some funding. They calculate the ability to pay and accordingly. Now we have got other governmental methods, right, Ayushman and all that. So whatever it is, we might, on a scale of 10, we are doing 10 lamas now, we might reduce it to 5 if we use certain principles which we have discussed today. Okay.
Sir, in fact, we have also said it in the guidelines very clearly. I understand what Dr. Mehta is saying. So I face some brunt of it, not all brunt of it. But having said so in the public sector, we have said that decisions on end of life, admission or discharge must not take finances in account. That is what is the position, and that's the legal position.
That's what you and I have written.
Yeah,
that's what we have written
it. So the answer to you is we do not recommend it. That's it. I won't say beyond that, and that's it. And the next question, sir, is quickly we have to finish it off. What if a patient discharged with end of life care decision now present to emergency room with bradycardia, low GCS? Now family wants everything to be done. What to do? We have sent it. They have agreed. We have discharged them. They taken home. They brought it back.
You see, family can change. The patient can change their minds anytime. Okay, let's be honest. But if you have addressed their queries and their apprehensions well, you see, by and large are consistent in their decision. Going forward, I think we should have these decisions. There's something called POLST in USA, most in some other country, which means physician physician orders for life support treatment. Okay, physician orders. When the patient is up to it, when we are anticipating, crisis, but with a patient, you sit down, you can take collective decision between the two, what treatment to take and not to take. Okay. Once you take that decision, it goes into the digital, into EMR, so that across ecosystem, you got the false decisions. This can happen in our country. We are all going digital more fast than any other country. So it can happen that in the EMR you have it, and the patient turns up in the ER, you have it available to you, what the pulse says. If it says there is no CPR, don't do it.
So I think
unless there is a revision of opinion by the family that says, no, we decided this, But we want it done now, then do it.
So at the end of the day, it is the family wishes which will take over than your beliefs and your things. So at
Yes.
all the time, the center of attention of yours should be patient and the family.
Yes.
So we have to follow the wishes there, even it may be against our own value system. So I think that is very important. We must not have patriarchal in our enforcements. So I think that's the fundamental thing which we need to understand. This is how now the medicine is evolving. The time has gone. And last question, sir, is DNI, DNR signed by patient's relative valid from legal point of view?
Yes, it is. It is valid because it's a withholding decision. The ICMR has got a whole document on DNAR. ICMR is a statutory body. So from both sides, you're absolutely fine. Only thing that the law says, don't do covertly, okay? Whatever you do with transparency. So documentation, transparency are a must. It is no good not doing CPR and not writing also. Or you go through the motions, sham CPR, those things are not doing.
Sir, in fact, what I have realized is if we are honest, if we admit sometimes inadvertent act of omissions do happen, it is in the intensive care units, it's a very complex environment. People appreciate it. Patients appreciate it. They are angry much more. They are seeing what is happening and we are not accepting it. So I think the moral of the story, what Dr. Mani has said is be transparent, be clear, try to talk to the family. It's not the patient or it's not an organ. It's some living one who's someone. Talk to the family upfront from day one itself. Take them on the same plane. Probably it will be much easier for us to make a decision making, good or bad, whatever the way you want to look at it. But obviously, decision making is for the beneficiaries, and that fundamental principles of ethics have to be followed and ensure it that the care is not only provided to the patient, but also the continuum of care continues to look out. We forget, because if you see the data shows they are also extreme depression or anxiety, because these are the issues which people are not ever ready to train with it. Same is true for the medical professionals also. And I think it was an excellent and enlightening thing for me, at least, Professor Dr. Mani, sir. Thank you so much for it, and Dr. Mehta for the final comment and conclusions.
So I think we have very nicely covered the case and followed by what should be done in different scenarios. I think it is very topical and it is very relevant in a particularly resource restrained country like ours, where we unnecessarily waste resources and family gets completely wiped out financially and emotionally. So there is, I think, we can play a very important role in the handling of the whole situation. And I must conclude by, I think, thanking first Dr. Dhruv for suggesting this topic, and secondly, for the tremendous contribution which Dr. Mani has made to this particular aspect of critical care. I think it's a path which is treaded by very few people, and I think he has led it from the front. And fortunately, we have seen the conclusion of the thing. It has been a particularly productive effort which he has put in. So we all, I think, bow to you for what you've done for this particular topic.
Thank you, friends. And, thank you very much, Dr. Chaudhary, Dr. Mehta, for this beautiful platform and for the organizers to enabling all this. And thank you, my dear friend, Sanjeev.
Thank you, sir.
Thank you for a great session.
Thank you, Sanjeev. It was a good case. I think it brings all of these issues where we are doing a lot of oncology, like my department. And this is a debate I continue to have with my youngsters. But I said, okay, make your own opinion over a time. I'm not forcing and enforcing. Thank you so much.
Okay, folks.
Prateshji, thank you. Manojji, thank you.
Thank you, sir. And today it's really a great day as we are completing the 1 year with such a beautiful web series, Pearls of Critical Care. Today we are at the end of 12th session of Pearls of Critical Care. And I, Arun Chadha, Vice President, on behalf of Intas Pharmaceutical, would like to propose a hearty vote of thanks to all the honorable delegates who blessed us with their presence in the last 12 sessions of Pulse of Critical Care. It's audience like you that make the presentation awesome. Thank you very much for your unwavering attention throughout the presentation. And I would like to thank our Honorable Course Director, Dr. Yatin Mehta sir, and Dr. Dhruv Chaudhary sir for designing such a fantastic web series on critical care, in which every month on third Friday, one interesting case is being presented by the institutions and the hospitals, which will be very helpful to all the resident doctors, DM and DNB students. We are very thankful to young Dr. Sanjeev Kumar Jha for presenting the excellent, unique case. Further to this, I would like to thank Dr. R.K. Mani sir, Director Clinical Services, Pulmonologist and Critical Care at Yashoda Hospital, for providing investigation and the other things in such a great way, sharing their experience in this case, providing the important learning points and proceeding of the unique things. So the entire presentation will be extremely helpful and informative to all the participants and those who have participated today. Once again, thank you for gracious presence. It's been pleasure being with all of you. Thank you for your patience, and we will meet again on 16th of February 2024 with yet another most awaited next session of Pulse of Critical Care. Till then, stay safe and take care. Thank you. Thank you, sir. Thank you very much.
Thank you, sir.
Thank you.
Thank you all.
Thank you. Thank you, sir.
Thank you, sir.
Thank you.
Supporting.